8 minutes for their cases, another 2 to 3 minutes for discussion.
Okay.
So we'll be taking it for 1 hour, 8 to 9. So 1 hour from total session.
Okay, for me, so you just guide me and I will do as you
Sure.
say. For me, it's okay.
Sure.
Yeah, no problem.
Sure.
Thank you. Thank you very much.
Yeah. Naresh, I think we are live, I think.
Yeah, we are live. Yes.
Yeah.
Let's start.
Neha, ma'am, you can start introduce.
I can start, okay?
Yeah.
Neha.
Good afternoon, good evening, everyone. So today we'll be having Indian Arthroscopy Society IS Academic Monthly Webinar, July 2025. So today we have international speaker for expert talk and 3 case presentations, and we have expert moderators, Dr. Ram Chidambaram and Dr. Karthik Selvaraj from Chennai and Coimbatore. So I would like to hand over to Dr. Sridhar for further this thing.
Yeah, thank you so much, ma'am. So quickly we'll go to our academic meet. So we will have an expert talk by Dr. Benjamin from Slovenia. So he will guide us through the patches in the rotator cuff repair. Then we'll followed by 3 case presentations. So to our moderators, Dr. Karthik sir and Ram Chidambaram sir.
Okay.
Yeah. So Dr. Benjamin, you can start.
Okay. Do you see my screen?
Yeah, we can see that. Yes, it's visible.
Thank you, Benjamin, for the kindly accepting our invitation to present here. Thank you very much. Please start.
Okay, so I'm Benjamin Marjanovic from Orthopedic Hospital Valdoltra, Slovenia, Europe, and I'm really happy and honored that I can speak to such an estimated association like Indian is. So I'm really glad. Thank you really much for the invitation. Those are my disclosure. They are somehow related to this talk because mostly of those companies produce their own patches and they have our own biologist solution for this problem.
Benjamin,
what
can
we
you
can
put
say,
in a presentation mode, please?
it's not in presentation mode, I'm sorry.
No, it's not presentation mode.
It is in the slide mode. Just keep on the presentation mode.
Full screen.
It's in
So we can see the full screen.
It's a full screen now?
Not yet.
No.
You need to click on the full screen icon.
Yes, I
It
think he
is-
has clicked.
At least I see it
But
on
he-
my. I see it in full screen. Now it's in full screen.
Click here.
Well-
No, not yet.
Now it's a problem because I have on my computer, I see on full screen. And you don't see in full screen. So you see now in presentation mode?
Presentation mode, yes.
So problem maybe if I do
Can
like
you
this
stop
now?
share? Stop share
Yes.
and I think
Reshare it again.
Okay.
Reshare it.
Okay. I will reshare it. Okay. Okay. Now I change something. I will see if it works now.
Yes, we can see that.
It's in full screen or is in presentation?
No. Presentation.
Still
Now
in presentation mode, sir.
And now?
No.
Still. Yeah, this is a problem because I see it on my computer in presentation mode. I will do another time. Okay, I will do like this. I will start sharing and I will change computer. So change Zoom. We can do like this now. Maybe now will change. It's still in presentation mode?
Yes.
This presentation mode.
Okay, then I think
Yes.
we go ahead.
Okay, wait, I will start again. I'm sorry, guys, for that, because I don't know why. Maybe because of the screen of the computer, because maybe the computer is in another screen. sharing.
I think we can go ahead.
Yeah,
go
go ahead.
ahead.
Okay.
Yeah, shall we just go ahead with this? Yeah.
Try to share entire screen once, please.
Otherwise, the videos and all will not play in this one, right?
Yes, sir.
Okay, I will go forward. So we can say that today we are performing more and more rotator cuff repairs, and arthroscopic cuff repair today is the most common procedure we are doing in shoulder surgery. Unfortunately, if you look at this slide, in the last 30 years, we are still on the same level. So we are performing more and more research, more and more surgeries, but still we are where we were 35 years ago. So the postoperative score, the number of intact cuff, it's almost a flat line. So some puzzle is missing and we don't know exactly what it is. We know that the bigger is the cuff tear, the lower will be the probability to have healing after the repair. But this is nothing new. I found here at least 10 researches, 10 to 15 years old, that found the same things. So 10, 15 years ago already people know that bigger is the cuff tear, lower is the healing rate. I also did my own study. I enrolled 300 patients, do the cuff repair, and look at 2 to 4 years follow-up, and find out that the degenerative big tears have more than 35% of non-healing. So every third degenerative big tear do not heal, even if it's completely repaired. We can say today that crucial if you want to have good outcome is patient selection. We know that the small tears, patient with good biology, a patient with good compliance and a good rehabilitation will have better outcome. But the most important thing is our procedure. So how we execute our procedure. It's really important that we know how to do correctly the repair. And today in 2025, we are in arthroscopic era, and most of the procedure that once was impossible to do arthroscopically, today we can do it without any problem. And also the same is with cuff repair. I will not say that if you do an open repair, you will not have a good clinical outcome. The problem is with open repair that you will have bigger, more serious complication.
Guys, I think our PPT is not advancing because he's seeing on a screen display
Yeah.
and then presenting the PPT. So we don't see we see the same slide.
You see something? Because someone is on my screen now. I don't know who. So someone is on my screen now with the mouse and is moving something. I don't know what exactly he's doing.
Sir, I have asked for a request control of your screen. So I am trying to make it into slideshow. That's it. But
Okay.
this is
I will
not.
go forward. Okay.
It is not. I will give up. Yes.
I think as Naresh suggested, he can unshare and then share the entire desktop. That might work.
Yes, sir.
You can share the desktop. I think that is the best option. Otherwise, the slides are not.
Okay.
Please give access for your.
Okay.
Yes, that's
Now it is coming,
Yes.
sir.
Now it's fine.
That's good.
Now it's fine.
Fantastic.
Okay.
Thank
Thank
you.
you. So I will go forward.
Perfect.
So
Yeah.
massive rotator cuff tear is not the same as irreparable. Massive, it means that there are big tears, greater than 5 centimeter, involving 2 or more tendons, high fat infiltration. But those kind of massive tear we can repair. We have many techniques how to release the coracohumeral ligament, how to release other structures to bring the tendon laterally. Irreparable is another thing. So not every massive tear is irreparable. Unfortunately, massive tears have many different clinical presentations. So the patient could be painful, could be painless, could be with good range of motion, and even could be pseudo-paralytic. And unfortunately, after 60 years old, every second person we find on the street have a calf tear, and 2/3 of them are asymptomatic. So this makes to us a really big problem how to deal with those kind of condition. So here I put a video of two patients of almost identical radiological presentation, but after the conservative treatment, after corticosteroid injection, one on your left side of the screen, so the one video on the left, probably will go home and say to him, you can go work normally. One on your right side probably will be, I don't know, or for some superior capsular reconstruction with located with the biceps, or even for reverse shoulder arthroplasty. We will discuss later about that. So where lies the clue, and why we have so many different presentations in massive tears? Because everything is in the balance of the shoulder. If we have a torn calf, but the deltoid vector force are counterbalancing the rotator cuff in the same way, so the ball is on the socket, we can normally move our shoulder. But if we have a torn calf and the deltoid is hypercontract, then we will not be able to move the arm because of cranialization of the humeral head. Today we know that every condition that produces pain in the shoulder increase the contraction of the deltoid, and this produce cranialization of the head and reduce the range of motion. So our goal in massive tear is to restore balance. We know that heel tendon is the best way to maintain balance in glenohumeral shoulder. And this is also the reason why partial repair have so good clinical outcome. So mostly of the articles out there, when we talk about massive tears, compare their procedure with partial repair. Today, we all know what is superior capsular reconstruction with located with the biceps. In the past, we did a lot of latissimus dorsi transfer. We don't do it now anymore because we know that with other procedure, we have almost the same clinical outcome for massive tears. And pseudoparalysis, glenohumeral arthrosis, massive tear and stiff, unfortunately, reverse shoulder arthroplasty is the only way to go. So today we have a big problem dealing with massive tear because we have higher degree of non-healing. And some puzzle in our knowledge is missing. And probably this puzzle is the biology. So if you now remember the second slide I showed before, the 35 years steep curve of articles, but the flat clinical outcome, probably the answer is here. So is the biology, because we didn't think enough about this really strong weapon that we have in our hands. And in the last few years, most of the companies start working on these weapons. So basically, when we have a calf tear and when we do a repair, we can work on two different levels. So we can work in the level between the tendon and the bursa, so between the tendon and acromion basically, or we can work between the tendon and bone. And we have many different biological solutions how we can improve healing. So let's look at those. The most important and the one that mostly of the research is now directing it is the interface tendon bursa. Why? In 2022, Mazzoca from US won a Nero Award for one really nice research. He demonstrated that the amount of stem cells in the bursa, so in the place between the tendon and acromion, is the same as an amount of the stem cells inside the bone marrow. And he started taking those stem cells, cultivate them, bring it inside after the repair of the calf in the mouse, and found that basically 86% had a reduction of the retinal rays. So bursa is extremely strong area where we can work. Unfortunately, we can't control the stem cells from the bursa, but we can improve healing from the bursal side. And this is the reason why we have many different patches. We basically divide the patches in two big groups. The one are so-called the onlay patches, the one who don't have strong they have a strong healing potential, acting basically through collagen type 1, but they don't have a tensile strength. Then the second category of biopatches are so-called bridging patches, like pitch patch, is the one who increase the connection between two sides of ruptured tendon. No healing potential, but increase the strength, reduce the return rates. There are many articles who try to find out which is the best patch for the indication, when to use in pasta, when to use in full thickness tear, when to use in massive tear. But for now, we don't have a clear answer which of those patch is the best. I put here 3 video of 3 different patches that we are using in Europe. On your right side, on the top, you can see a BioBrace one. This one is made just of collagen type 1. You can use it in full thickness tear and in pasta tears. Unfortunately, it's not the best for massive tears because it don't have a tensile strength and it reabsorbs quite fast. The second one is a BioBrace. I don't have the video, unfortunately. This one, it's not available still in Europe. I just use it sometimes in cadaveric area, so I don't have experience with it. We are wait for this in Europe to come. It's a combination of collagenic patch and PLLA, so have a tensile strength and some biological potential, but again, the long-term results are not there. The last one, the inferior one, is a bridging patch. With this bridging patch, you just connect the 2 parts of the ruptured tendon and reconstruct it to the tuberosity. Again, you will ask me which is the best for what. We can say with the experience we have and with reports from other countries, we can say that pure collagenic patches are best for partial repair and for full thickness repair without retraction. The bridging patches are best for massive tear, so bigger tear when also the tensile strength is important. If we move now to the interface tendon bone, the most old procedure that all of us performed when we try to increase the healing between the tendon and bone is microfracture. So I didn't put here microfracture inside because it's not a true, I will say, outsource of the biology, but it's somehow like a shaving of the surface of the bone or do some small holes inside that the blood and the stem cells that are inside in the bone comes out. So I will prefer to talk about PRP, stem cell and scaffold. PRP, you probably all know it. It's worldwide used. There are hundreds of articles who explain its effects in calf healing. Unfortunately, mostly of those articles, or I will say 50% of the articles who speak about PRP and calf repair are lack of minimum information for study evaluating biologic in orthopedics. This is called MIBO. Why? Because companies are behind, they pay a lot of money, and there is not a lot of scientific evidence behind that. So till 2025, we can say that PRP really improve healing of the calf repair. At least 50% of articles say yes, 50% say no. So it's a great zone. Regarding the stem cells, many studies are around there on animals. They have really promising result. They increase the healing rate for up to 90%, but in humans, we don't have enough studies. And what is the reason? Because we are really afraid about the transformation of the stem cells in something else. Because we don't have the magic trigger, the magic stick to say, okay, the stem cell will transform into tenocyte or the stem cell will transform into chondroblast. We don't know how to do it. Maybe in the future we will know the receptor and we know how to do it. Regarding the scaffolds, many studies were done how to produce a scaffold, bring inside of stem cells or PRP or blood and putting between the tendon and to bone. But there was a lot of failure because of foreign body reaction. Because once the Sharpei fibers start to producing between the tendon and the bone, and if you put something in between, you may have a failure. And a lot of failures was in the past. So in 2025, we can say that the area where we must work is between the tendon and bursa and not between the tendon and bone. So in conclusion, when we have a massive tears, we must try to do at least a partial repair if a full thickness repair, it's not possible, because in that way we will increase the balance. We need a large portfolio of treatment option because we have many different clinical presentation of massive calf tears. If we talk about biopatches, bursa tendon interface for now have the most promising result. If you ask me which is the best patch, I can answer you. I can say that for now we need at last two different type of patches. So the collagen one to put on the top, or the bridging one to increase the strength. And we need more studies to define the best patch. So in really conclusion, in shoulder fields, every 4 to 5 years, we change our philosophy. We change our, I will say, mentality, how to deal with shoulder. Everything is, I will not say fashion. So it's a really small border between fashion and knowledge. So I really like to speak again in front of you after 4 years and see that those conclusions are just fashion and they will disappear like latissimus dorsi transfer, or there are a true science. This is my congress next year, this year in November. If you're not able to join it live, you can click on BMET and everything will be streamed. So 12 live surgeries, 60 speakers, key opinion leaders from all over the world, and it will be a nice congress. This is the view from my OR. A lot of Indian people come regularly to me, so you are all invited to look not just at the surgical field, but also from out of our OR. Thank you very much.
Thanks. Thank you, Benjamin. Nice brief overview of the patches and the current indication. I think the indication is clear, repairable cuff tear, and we want to reduce the rate of re-tear. Correct? And the indications could be a massive cuff tear or large cuff tear, which is repairable, or a partial cuff tear where you want to augment. Now, question is, what is the long-term results?
Yeah, the problem is that now, not just me, but also a lot of surgeons around Europe, if you ask me this question 5 years ago, I will say latissimus dorsi transfer is the way to go. So we perform a lot of latissimus dorsi transfer for posterior superior massive tears. Good result, but unfortunately long rehab and quite difficult for the patient. Today, we are doing more and more superior capsule reconstruction with long hand of the biceps. So in somehow incorporating the long hand of the biceps, leaving distally inserted. And in that way, we put some biology inside. And for the cases where is not biceps present anymore, I will use patch. So my answer to you is patient without biceps where the biology is not the best.
Yeah. Now, other question is, what is the complication of this use of patches? Because with certain biological patches, it was noted that around 3 to 4 months time, the patient develops some inflammatory reaction or something like that. But with the synthetic patch, it is not there. So your experience and your observation, please.
Yeah, so the problem of every calf repair is that the calf repair go through an inflammation phase. The inflammation phase starts usually after 4 to 5 days after the repair. So in the 4 to 5 days, even if we give to patients some, I don't know, non-steroid anti-inflammatory drugs, we will not reduce the healing. The problem is from 5 days forward. And if we put any kind of material or under the calf or over the calf, it can overstimulate this inflammation. And this produces stiffness and this produces capsulitis. So it's really difficult to say what is capsulitis, what is low-grade infection due to Propionibacterium acnes, or what is a normal super healing because of the patch. So if we will be able to answer what is low-grade infection, what is super healing, and what is capsulitis, we will be super happy, but we are unable to answer what is what.
Okay.
And this all because all those three conditions produce stiffness. No.
Any questions from you, Karthik?
Yeah, Dr. Benjamin, what is your long-term follow-up so far?
Yes.
Yeah, long-term follow-up with patches or with
Yeah.
massive tears.
Patches.
Patches.
Yeah, it's like that. I can answer to all of my part of Europe. The patches is like that are really expensive. So the people who work in public have a lot of problems to use patches. We have quite a good DRG, so we can say to the insurance that we are implanted a celastic implantation, like a balloon. If you remember a balloon from Orthospace, we use the same reimbursement. So this is the main problem of our region because patches are really expensive. So we need to do 5 calf repair to bring back the money for one patches. The second problem is how can we demonstrate that the patches really improve
Better.
the healing, because there are so many different risk factors that can affect the outcome after the repair. So it's really difficult to demonstrate it. And if you look at the articles, they have all the same problem as we have. Difficult to demonstrate the true effect of patches. We know that it works because patients are better, but to demonstrate it is difficult. It's really difficult.
So excellent. When you have the elongated biceps, then you avoid doing a patch. Is that what you do? I mean, if you have a long head, you just use a long.
Yeah. Good question, because this is one indication for putting the patch over the repair. Every time when you have a biceps, you move it as posteriorly as you can, fix it, and reconstruct the remnants of external rotator over the biceps or on the biceps. And putting the patch over will increase the biology. So this will be one really good indication and also really nice study to do, because now, at least in my experience, every massive tear have a superior capsule reconstruction with no head of the biceps. So this is a really good idea, basically, to do a study.
When you do the long head, do you just do a rerouting of the long head? How many anchors? How many anchors do you use for the long head? Where do you put your anchor?
Yeah, now I try to leave the distal part of the biceps. I don't cut it anymore. So I do the rerouting. I don't do the rerouting in the way like Chinese and Japanese people do. I don't do a new sulcus, but I just put 1 centimeter laterally and 1 centimeter posteriorly, a triple loaded anchor.
Yeah.
Fix it with 3 lasso sutures and 3 lasso knot, 1 anteriorly and 2 posteriorly on the biceps. And then with the posterior part of the biceps, I partially detach the transverse ligament, not completely, but just partially, just the superior part. And then always repair the infraspinatus with at least 1 or 2 anchors, and then side to side between biceps and infraspinatus, because SCR at the end, what it is? It's somehow a prevention to re-rupture of the external rotators.
Now, Benjamin, I've been doing exactly the same as what you say, and I've had very good results with biceps rerouting. But I have not been doing it for a long time now. Probably you would have been doing it for a while. Now, whatever we do with this biceps, have you followed them up with MRI or imaging to see what's
really
happening?
Great question.
Yeah.
If I have time, just 2 minutes. One of my friend, Achilles Bustiadis, is the guy who bring this technique together with Johannes Barth from China to Europe. Because in China, you know, they had problem with reverse shoulder arthroplasty. They were not allowed to use it because of documents and so on. And they're masters in using the biceps in 100 of different ways.
Yes.
And Achilles many years ago told to me, Benji, why you don't start using the biceps? Why are you using all this time the latissimus dorsi? And I said to Achilles, come on. We are latissimus guys, you know, really good result. It works really well in a mini open fashion. Arthroscopically, you spend 40 minutes. But then after a few years, he convinced me. And now I will say it's like 5 years. I'm regularly using long head of the biceps, and all my patients receive an MRI. So all my patients receive an MRI at 1 year.
Okay.
And I must say that mostly of the biceps are intact. I don't know why, or it's because I sutured them with 1 or 2 side to side to the infraspinatus, or because you completely change the biomechanics of the shoulder. I don't know, but the biceps remains there.
Fantastic.
See, the biceps is providing both biological as well as structural support. Agree. But when is
Exactly.
your
So
indication to add a patch on the top of biceps when the cuff
yeah,
repair quality of
yeah.
cuff is not good? Would you
Yes.
like to add, what is your choice, a biological patch or a synthetic patch on the top of it?
I will say like this, biceps, it's a perfect vascularized autograft. So it's something similar to the coracoid in lateral gel. Because the blood supply is there, and
Yes.
when you suture it to the cuff, you somehow increase the amount of blood that comes there. It's impossible to demonstrate it, but from theoretical point of view, it's a really good idea.
Probably
So
increases the scarring there. So by the scar helps. Yeah.
exactly. So I like really, really much using the biceps. And as a colleague before asked me, it's a really good idea to put a collagentic. I will probably use all a collagentic or BioBrace that you are able to use it over the superior capsular reconstruction. This will be a really good idea also for do a study. To two groups of people, one with, or maybe three groups, normal repair, SCR with patch and just ACR. And then maybe 1 year follow-up to see the clinical outcome. This will be a good idea, yeah.
Benjamin, any experience with the human dermal allograft? Has it made it entry in Europe?
Yeah, I have, but just bad experience. Just bad experience. I did 10 cases. It was a few years ago, and all of 10 cases failed.
Was it
All of
porcine
10
or
cases failed. I don't know
human?
what is your experience, but my experience
What
is
is
not so
it,
good.
porcine or human?
Porcine
Porcine.
dermal allograft. Yeah.
Porcine is different. That has got some reactions, etc. withdrawn from the market. But dermal allograft is a new thing. Anyway, wait to see. Okay.
I don't have experience with dermal. I'm sorry, guys.
Fantastic. Thanks very much. Any other
question, Sridhar, from the chat or?
So,
Dr. Benjamin, what is
Yes,
your
sir.
implant for fixation of the patch over the cuff?
So depends from the type of the patch you are using. I don't know, the collagen type patch, you just fix it with stepless. I usually don't fix it laterally on the tuberosity anymore. So just with normal stepless and that's all. If you use BioBrace, you know they have many different ways how to fix it. The way like Canadian guys do, when they firstly do a cuff repair and then fix it on the top. You can incorporate it in the repair and then just fix it laterally or the remnants of the sutures. When we talk about pit patch, it's another thing. So you must have a really strong fixation. So I will say different type of patches, different type of fixation.
Okay. Thank you, sir.
Sridhar?
Yeah, okay, sir. We'll move on to next case.
Dear sir, is my slide visible?
Yeah, we can see.
Is it full screen now?
Yeah, we can see you.
Thank you, Dr. Benjamin, for a lovely presentation. Good evening, everyone, respected dignitaries and faculty members. It is a privilege to present today at the National IAS Forum. I'll be sharing insights from my work and surgical experience. I hope it will contribute meaningfully to our collective learning. So, as we all know, our godfather of shoulder surgery, Dr. Charles Neer, he published this pioneer article almost 55 years back, in which he stated that with such fractures, if they are almost 1 centimeter displaced or less than 45 degrees of angulation, they can be managed conservatively with satisfactory outcome. But in today's scenario, is this still applicable? So after 30 years, this paper came out from the US and was published in JBJS, in which they evaluated the biomechanics of the shoulder after a GT fracture. And they concluded that even 5 mm of displacement can cause significant dysfunction of the shoulder joint, leading to changes in the mechanical vector of the supraspinatus and increase in abduction forces of the deltoid. At this stage, we need to understand the relationship between the rotator cuff and the deltoid. The rotator cuff acts as a depressor of the humeral head and pushes the humeral head against the glenoid. Because of this compressive force on the glenoid, this activates the deltoid and causes abduction of the arm. So in cases of GT fractures, the rotator cuff function is lost. So this compressive effect is also lost, which makes the deltoid inactive, and the deltoid has to overwork to cause abduction. So this is a typically we'll see loss of abduction in cases with GT fractures. So what evidence do we have? So this paper came out from the Columbia University in 2012, stated that even 5 mm of displacement should merit surgical intervention. In 2015, this paper from Cairo went one step ahead and said that in very active patients, even as less as 3 mm of displacement should merit surgery. Then why so much discrepancy? So we need to understand the anatomy of these fractures. As we all know, most of these fractures are avulsion type of injuries. Avulsion literally meaning to like tear away from the parent bone. And what tears it away? As we all know, it is the rotator cuff. When you look at the attachments of the rotator cuff, the supraspinatus is attached superior to the GT. And when you see the infraspinatus, it winds around the supraspinatus and attaches to the posterior aspect of GT. Thus, this attachment of rotator cuff causes a posterior superior displacement of this fragment. So the final vector of displacement in such injuries is a posterior superior displacement. So when we understand the pattern of such avulsion injuries, it is very important to see that such fractures displace superiorly as well as posteriorly. So does displacement pattern really matters? So this literature clearly shows that the fractures which are displaced superiorly and posteriorly, they have a poorer prognosis than any other type of fractures. So to evaluate such injuries, it is important to have a true AP or a Grashe view in which the glenoid, both the anterior and the posterior margins of the glenoid are aligned, and the humeral head is not overlapped with the glenoid. So when we tilt the scapula in 30 degrees in the plane of glenoid, that's when we start to see the joint line and we can identify these fractures very easily. So it is very necessary to have an alternate view, which can be a trauma axillary view or a Wellpau view. And if still in doubt, we can go for a CT scan. CT scan will definitely pick up these X-rays, and they will also tell us about the pattern of these X-rays, fractures. So if we look at the pattern of these fractures, they are divided into 3 types. The type 1 being the avulsion type, in which a small piece of bone is detached from the parent bone. In the split type, which are vertically very unstable, and the depression type, which are classically associated with fracture dislocation. So what are the treatment options we have? So when you choose a conservative option, we need to keep in mind that you need to have serial X-rays to observe the patient. So the Journal of AOS clearly stated in their guidelines that surgical treatment results in better functional outcome when patients have more than 5 mm of displacement, and surgical treatment can be considered with as little as 3 mm of superior displacement in young, active, and sports persons. They also stated that posterior GT displacement has been demonstrated to negatively impact functional outcome independent of the superior displacement. So this is my case of 45-year-old male with a history of RTA 1 month back. Movements were grossly reduced and painful. He came to me with these X-rays, which clearly show an avulsion type of injury. And now I believe we all will agree that such fractures, this particular fracture will require surgery. So what are the options are available to us right now? So the traditional teaching has been to use cannulated screws, which can be partially threaded, or a tension band. But we can get good hairline fixation with such techniques, but these techniques have a lot of pitfalls, which these techniques provide only local compressive forces on the fragment without any adequate load distribution. These techniques do not eliminate the rotator cuff tension on the fragment, thus leading to long immobilization and delayed rehab. You can clearly see when you start mobilizing the patient, and the patient might come up to your clinic in the follow-up with a picture like this. Here, you can clearly see that the fragment has cut out and migrated superiorly. In this next modality is a plate osteosynthesis that these are very low profile plates, well contoured, which will provide a good compression buttress effect on the fragment. There will be periosteal stripping, and they'll decrease the blood supply. But even these plates do not eliminate the rotator cuff pull on the fragment. In this X-ray, you can clearly see on day one the surgeon has achieved excellent fixation. But during the follow-up, as the patient mobilized, the fragment has escaped and it has migrated to the subacromial space. So even the literature says about the transosseous braided technique, which is suggested to be superior than a simple tension band construct. This biomechanical study showed that on cyclical loading, we are better off with a transosseous fixation or a supplementary fixation rather than a plain screw fixation. So which options do we choose? We have come up with new techniques like suture bridge, modified suture bridge, double row suture anchor fixation, which both can be done arthroscopically and open. And there is enough recent literature present on these techniques. So coming back to my case, a 45-year-old male, 1-month-old injury, gross restriction of movement and painful with avulsion type 1 injury. So my approach to this patient was with an anterolateral mini open approach, keeping in mind that the axillary nerve lies only 5 to 6 centimeters from the lateral border of the acromion. So keeping my incision very short from 3 to 4 centimeters and splitting the deltoid along its fibers, achieving adequate soft tissue release, and the fragment was identified in the subacromial space with an intact cuff. So I achieved a 4-point fixation of the rotator cuff using two 3.5 mm titanium self-tapping anchors for the medial row. The sutures were parachuted over the fragment, providing equally distributed compression force on the GT. Final lateral row fixation was achieved with one single 5.5 knotless anchor. This is the final construct which I achieved. As you can clearly see, we were able to eliminate the rotator cuff pull on the fragment. We were able to achieve an anatomical reduction. And because of the parachuting of the suture anchors, there is equal distribution of force for compression of the GT fragment. The patient was immobilized for 1 week immediately post-op, and assisted pendulum exercises were started after 1 week of surgery. This is the outcome of the patient at 3 weeks, and there's a complete functional recovery at 3 months. The patient has full abduction, full forward flexion. This is the internal rotation of the contralateral side. This is the internal rotation of the operated side, and the patient has recovered very nicely. So the take-home message from this talk can be the conservative management can yield good results for displacement. 3 to 5 mm in displacement of 3 to 5 mm in low demand patients, but with a guarded prognosis. Early treatment is most important. Adequate soft tissue release is important. Elimination of the rotator cuff tension on the fragment is the mandatory key point here. Correct identification of the displacement pattern, anatomical reduction of the fragment, and early rehabilitation is the key. Thank you. I would like to thank the IAS Society for giving me this opportunity. And I would like to thank my mentors for teaching me and guiding me throughout my process. Thank you so much, everyone. Any questions?
Excellent. Excellent presentation, Sarthak. Good work. And you reviewed the literature also. I think it's pretty clear from what you said. Is Ben still attached?
Sorry, sir?
Is Benjamin still around?
I think he's mute.
Yeah, I'm here.
Okay. What do you do for your graded tuberosity fractures, Ben?
So as Sarthak clearly showed, it's a really good procedure. I do the same thing but arthroscopically. But there is one big problem. If we have osteoporotic patient,
yes,
it happened to me more than once to have a pull out of the anchor. So I start with a simple small 2.9, 2.8 all suture, and I end up with, I don't know, 5.5, 6.5 at the end, because in osteoporotic patient, it's a really big problem how
Right.
to fix this kind
Right.
of condition. In males, it's perfect, so it works really, really well. But
Yes.
in females,
Right.
it's problematic. Elderly
So
females.
the new HA coated anchors have come up, and we can fix these anchors with an osteoporotic bone with the bone cement as well. So I believe that will be a game changer in these fractures. And
Yeah.
Sarthak, those things that work well for rotator cuff repair issue, but not for tuberosity fractures,
okay,
the
sir.
bone cement augmentation. I think the parachute technique is good, provided you have a clear one-piece GT fragment. Sometimes you have a big fracture or almost fragmented or weak
Communicated.
GT fragment. So my personal preference would be to use a suture tape configuration anchor
Yes, sir.
medially.
Definitely,
And then
sir.
you take the tapes, so that you put two anchors distal row, so that the tension is evenly distributed. As you rightly pointed out, offloading the tension of the rotator cuff is the key for success. Be you do
Yes.
it arthroscopically or mini open.
Sir, I read literature about doing the same procedure arthroscopically and open. So this surgery time for the same surgeon doing this procedure arthroscopically was 90 minutes, and doing it open was 30 minutes. So
Absolutely. It's a time intensive,
Yes.
labor intensive work if you do it arthroscopically. And I think sometimes we get lucky when the medial anchor just stays inside. Sometimes you put the anchor a little deeper, and then you make sure that the anchor is nicely seated and pull it out and see. Sometimes if you don't get a hold on the medial side, then all you can do is take a lot of bites. Sometimes go all the way down to the fracture, and then you can put one, if you can put an anchor, that's fine, or you can put a screw with a washer and tie all the sutures to that washer. Even that can work when you're doing it open. Sometimes if the fragment is very big and it is going very distal, then you can even put a small plate, it doesn't matter. So all that you covered quite well, and it's just to keep in mind that you have to have all the options in your theater while entering and doing this sort of thing.
definitely.
Sartak, I have a question. Do
Yes,
you
sir.
sometimes decide to go conservatively in this kind of patient?
Yes,
And then maybe
definitely.
just with normal debris arthroscopically just to clean the overhang of the
So,
fragment?
we do conserve such fractures a lot. If we have a depressed or an undisplaced fracture, or a fracture which is minimally displaced, a low demand patient, we definitely go for a conservative management. We just immobilize them in a brace and then keep evaluating them every 15 days, every 2 weeks. And if there's no migration, we just conserve them and then start them on rehab on fifth or sixth week.
Fantastic. Can move to the next presentation, I think.
Sure, sir. Thank you so much, sir.
Sir, good evening, sir. Is my screen visible to everyone, sir?
Yes, it's visible.
Yeah,
Yes, go ahead, Dr.
Yes.
Manivanan.
Yes, sir. Yes, sir. So, good evening, everyone. So, I would like to thank the members of the IAS and respected chairpersons and the moderators for this opportunity. I have a series of cases. So, this is a 45 years old female who had a trivial fall and presented with forceful audible snap following that trauma. On MRI, the coronal images show the truncation sign, where you can appreciate the signal increased signal intensity adjacent to the meniscal root stem. And on sagittal images, you can appreciate the ghost sign. And it is a straightforward meniscus root repair through pull-through suture technique. The root, meniscus posterior root has been found to be avulsed from the tibial plateau. And with regard to the pull-through suture technique, mobilization of the root to its anatomic location is necessary. The footprint should be decorticated using a curette and then with a shaver. Non-anatomic root repair is something equivalent to a subtotal meniscectomy. And while suturing the meniscus root, the first suture should be passed like about 5 mm lateral to the medial to the lateral aspect. And the second suture should be passed through the mid portion of the root, something anterior to the previous suture, in order to prevent eversion of the torn end of the meniscus. So these sutures should be tensioned under direct arthroscopic vision, and usage of arthroscopic cannula is advised to avoid soft tissue bridgings. And this is another case of 40 years old male presented with a knee pain for more than 3 months, and there was knee pain in deep flexion. Coronal images showing truncation sign indicating the root tear. And you can also appreciate the medial meniscus being extruded out of the joint space, sitting out above the tibial condyles. And we have done meniscus root repair through pull-through suture technique, and centralization stitch has been added for this patient. And this is the outcome following repair and centralization stitch after 6 months. A centralization stitch is indicated when the patient has extrusion of meniscus beyond 3 mm. And the purpose of centralization stitch is to avoid postoperative extrusion, restore the hoop stress, and to improve the meniscus function. And whenever a centralization stitch is placed, it is better to place it before the root repair stitches are tied down. And most commonly, the root tears are associated with the degenerative changes. So when the sutures are placed through the degenerated torn meniscus roots, they will not be able to hold even with secure methods. So the centralization stitch, when used, they share the load along with these pull-through sutures, and the chances of failure is less when we use centralization stitch in such cases. And there are so many studies that propose the centralization stitch. It is indicated when the extrusion is beyond 3 millimeters, and the degree of extrusion is increased when the knee is loaded and flexed beyond 90 degrees in patients having meniscus root tears. However, there has been no best described technique for using centralization stitch. Recent literature suggests that use of centralization stitch is effective to restore the native biomechanical properties of the medial meniscus. And this is a third case where a 40 years old female presented with knee pain for more than 1 year. And on X-ray, she had varus small alignment, and the MRI showing posterior medial meniscus root tears. You can appreciate the truncation sign, extrusion of the medial meniscus, and the ghost sign as well. Under arthroscopy, there has been medial meniscus root tear. Along with it, you can appreciate the cartilage changes in the femoral condyle.
नहीं बस
Is someone calling Manivan?
It seems that he has been cut off from the link, sir. He is not. He is trying to.
Maybe call him on the phone.
Yes, yes, sir.
I'll call him, sir. And in that time, we can start with the next presentation.
Yeah, sure.
Shall I start, sir?
Sure, sure. Go ahead.
I think he's. Dr. Manivannan? Please unmute yourself.
Ma'am, is my screen visible?
Yes.
Yeah, yes. So we have done arthroscopic medial meniscus root resection and high tibial osteotomy for this medial opening wedge osteotomy for this patient, and that's a post-operative scan.
Minimize your zoom, no?
Is it okay, sir?
No. What I am asking is, there is one extra window we are able to see on the screen along with your presentation.
Yes, sir. Yeah.
Yes, please go ahead.
Yes. We have done medial opening wedge osteotomy and arthroscopic root resection. And this is a post-operative scanogram where you can appreciate the weight-bearing axis passing through the lateral tibial spine. And this is a follow-up of the patient at 10 months. You can appreciate the left limb in valgus or neutral alignment, whereas the right leg is in some sort of varus malalignment. So, considering HTO in patients with varus malalignment is recommended, even for patients having varus of up to less than 4 degrees, or Kellgren-Lawrence staging of up to grade less than 3. High tibial osteotomy corrects the lower limb malalignment. It protects the damaged meniscus and redistributes the load across the knee joint to the lateral compartment. When done together with the medial meniscus root repair, it restores the hoop stress and redistributes the load across the knee joint, reducing the progression of osteoarthritis. However, there are many articles that suggest the functional outcome and scores are similar to the dual procedure when HTO is done alone as a standalone procedure. There are certain studies wherein they have done second look arthroscopy after HTO and medial meniscus root repair, and they have attributed that there has been increased healing of the meniscus and regeneration of the degenerated articular cartilage. But they also stated that the healing of the medial meniscus root repair is not associated with a better clinical outcome. So they could not attribute whether the HTO or the root repair is contributing to the similar functional outcomes. So finally, the take home would be when you have an isolated root tear, it is better to repair, and root tear with extrusion of the meniscus, root repair and centralization can be considered. When we have root tear with the varus malalignment, osteotomy with or without root repair is to be considered. I would like to thank everyone for this opportunity.
Very good presentation. I think you showed everything.
Yes, sir. Thank you, sir.
Any questions from anyone? So the thing is, right from the first case, though he was a 40-year-old patient, you said it was trivial trauma, right?
Yes, sir.
So what sort of trivial trauma was it?
Sir, something like
just a twisting injury while walking, or
yes, sir.
down from the stairs.
twisting injury while walking down the stairs, sir.
Yeah, so this is a very typical thing, getting down the bus or getting at the bus or stairs. They have a small twisting injury and they have a hair pop sometimes and they develop severe pain.
Yes, sir.
So now this cannot be called as a traumatic root tear. It is like a degenerative root which has given way, more like a acute on chronic root tear, isn't it?
Yes.
So as you elucidated in your talk quite well, I think HTO, a standalone HTO is a better operation in most of these patients, because we've seen that a lot of patients over the age of 45, 50 who undergo root repair. At some point, I mean, the survivorship of root repair is seems to be not that great. What's your opinion? What's your experience in that? How do these patients do well in long term, like 3-year, 4-year, 5-year follow-up? Does the varus progress? Does the medial joint OA progress?
Sir, I have not done so many of cases, sir. I have been done like a few HTOs for root tears, and so I am yet to follow up for 3-4 years, sir. So far,
I sincerely suggest that you keep track of these patients and see how the deformity progresses. Do they develop varus later? So some of us have started doing, even with 5 degree of varus. If we go in and we find more than grade 2 or grade 3 OA, grade 2 OA, we always had a HTO or sometimes do a HTO as a standalone procedure. Having said that, many others are of the opinion that you should add a root repair as well, because you actually normalize the knee anatomy by adding the root repair. But my skepticism about the root is that it's already a degenerate. Like, it's like a cuff, very bad cuff which is torn. You know, whatever you do, trying to put it back, it might not heal. So the value of root repair in the presence of H2O is definitely questionable. So we are moving more towards H2O rather than doing isolated root repair in many of these patients. You brought it out quite well. Thank you.
Thank you, sir.
I wanted to ask experts and our moderators, how frequently do they need a centralization stitch?
Well, that's the thing. So if you have to put a centralization stitch to bring the root back to its place, that means it's probably not a good root to repair. That's my opinion. So we tried all that, and then we still at 6 months, 1 year, patient is not improving. You kept the patient non-weight bearing for a long time, coming back with pain, this and that. And slowly at 1 year, you see the medial joint space going down, reducing, patients developing a little varus. So these are the problems we are facing with root repair. So what is your
Karthik sir, in your experience, sir, how long does a nicely done root repair patient stays pain-free?
Yes, so I have done root repairs right from 28-year-old. A 28-year-old patient coming with an ACL injury and a medial meniscus root, that's the surgery, that's the root which you have to fix. There is no doubt about it. A 30-year-old, 35-year-old, 40-year-old with absolutely normal joint, cartilage is pristine, acute root tear, and patient has severe pain on the medial side, popliteal area, then you repair the root. These root repairs heal, there is no doubt about it. Nicely done, null, a robust root repair usually heals quite well, and they do well. Then you don't need to have to worry about it. But we are worried about these obese middle-aged females, have a little bit of mucoid ACL, have a little bit of varus, have a little bit of degenerated root, probably radial tear next to. These are the patients whom come with pain. They ask for some sort of, they are not getting better with conservative. And as knee preservation surgeons, we are pushed, we want to do, something minimally invasive. And then almost half of these patients, they don't seem to do quite well.
I had a case, sir, who had a bilateral root repair, not at the same time. She had one root torn and she came with the symptoms. And we went in and the cartilage quality was not very bad. And after the repair, now it's almost 1 year. Patient is doing well. And she had a root tear 8 months after the first surgery. In that case, the cartilage was not not very great. So and still I felt like, okay, we'll just go ahead. There is no gross varus. So say like you said, just like 2 or 3 degrees varus. But that patient now, it's almost 6 months since I did the second route. Now the patient is saying that the second side which I did, she still has some residual pain. So maybe I was just thinking on your lines that maybe we should switch
Yeah,
more and more towards HTO.
once you start doing more, then you will see more of this. You've been just lucky with the first site, so it's good. I mean, if everything goes well, we have no issues. But and some patients, after 3-4 months, they develop acute severe pain. They develop a little bit of an osteonecrosis in the femoral
Oh,
side, and they develop severe pain. And
okay.
no, nothing other than a T-care helps them, or a uni. So
Okay.
all this has to be kept in mind when you're dealing with a root tear, which is a degenerative root tear. Anything else to add, Dr. Rajiv? Rajiv bhai?
Yeah, perfect discussion going on. I am in Hyderabad for TOSACON meeting, just enjoying
Why
talk
so?
and discussion.
So you should have been in 2 cities at the same time, not only one city.
Excellent talk. Yeah, by all the speaker. Thanks Ben for joining. Thanks Sarthak.
Thank you, sir.
So we'll proceed with the next one.
Yes, Ben.
Yes.
By Dr. Satish.
Yes. Is my presentation visible?
Yes, we can see. Yes.
Okay, so I thank sincerely IAS for giving this opportunity to talk about just arthroscopic subscapularis repair. I'll introduce myself. I am Dr. Satish Kumar from SKS Hospital, Salem. It's 2 years since I started my practice, and I think the category comes under beginner. So I'll just give my perspective about arthroscopic subscapularis repair. So we all know that tears of subscapularis have been under-recognized, and we need a high index of suspicion to diagnose the subscapularis tear. Proper physical examination along with MRI should be done to identify these tears. And with the advent of arthroscopy and advancements in clinical and radiographic detection and improvement in surgical instrumentation techniques, the results of subscapularis is excellent when done with right indication and right technique. So knowledge of presentation, detection, and repair technique of subscapularis tears are paramount for good results. So we all know the anatomy. So the origin is from subscapularis fossa, inserts on lesser tuberosity. Action is internal rotator, and it also contributes to the abduction of the arm. So typically, like any other rotator cuff tear, it presents in middle and older age. So males are more prone to have tears compared to sorry. Males are more prone to having subscapularis tear, and there is usually a history of forced external rotation. Pain is located in the anterior shoulder, and isolated subscapularis, though not uncommon, it usually occurs along with supraspinatus and infraspinatus tear. So tendon degeneration has been shown to occur in subscapularis at similar rates as supra and infraspinatus. So clinical examination, we all know that there are several tests to diagnose this subscapularis tear. So passive external rotation test, internal rotation lag sign, belly press, Napoleon's lift off, and modified lift off test. So this is a systemic review on diagnostic accuracy of clinical tests by Alexander Laderman. So they have come to a conclusion that all the four tests that are mentioned here have a specificity of 0.9, but sensitivity is less than 0.6. So none of the tests as a single test is individually reliable in diagnosing subscapularis tear. But however, if you combine the tests, at least 2 or 3 tests, or if possible all 4 tests, it leads to a reliable diagnosis of subscapularis tear. So MRI, what I look in MRI is the axial section. So that is the section where we can easily diagnose the subscapularis tear. So we can see as I have marked in the MRI photos. So you can see that from the lesser tuberosity, the subscapularis is torn and there is some amount of retraction and there is some effusion, which is indicative of some injury. And usually, any bicep subluxation is a clue to subscapularis tear. So these are the things we see in MRI. So classification, we all know that Lafosse classification is the most commonly used. The first type 1 is partial thickness of superior third. Type 2 is complete tear of the superior third. Type 3 is complete tear of the superior two-third. Complete tear of the subscap is type 4. And type 5 is along with tendon retraction and eccentric humeral joint. So indications for repair is a full thickness tear and partial thickness tear, which has failed conservative management. And a partial thickness tear along with full thickness supra and infraspinatus tear is an indication for repair. Contraindications, any patient with minimal symptoms, any associated arthritis, any guttular grade 4-5, any patient with who cannot comply with post-op physiotherapy, which is very important for cuff repair, and patient with significant comorbidities who may not be able to have surgical fitness, and any active infection. So as a beginner, why subscapularis repair is demanding is that compared to supraspinatus or infraspinatus, it is difficult to get orientation and visualization of the subscapularis tear. So first of all, identifying the LT and the footprint itself may be slightly difficult to get that orientation with our camera and the light source. We need to keep it in a way that we see that anatomically, especially when we are doing it in a lateral position. And if the tendon is retracted, it is usually difficult to visualize it from the inside the posterior portal, and sometimes we may need an additional anterior anterolateral portal to look at the visualize the retracted tendon. And it is difficult to mobilize the torn tendon, especially in chronic cases. We need adequate soft tissue releases to bring back the cuff back to the footprint. And again, difficulty in passing the sutures. Sometimes we need antegrade device, sometimes we need a retrograde device. And suture management, especially if we are planning to put 2 anchors, something like that. And as my boss always said, Dr. KNS sir, that we should have an arthroscopic surgeon should have some amount of experience in managing arthroscopic supraspinatus and infraspinatus tear without any struggle. And if once that is achieved by the surgeon, then they can go for the trying an arthroscopic subscapularis repair. So technique, we all know that we can do it either in beach chair or lateral. Beach chair has the advantage that if we are finding it difficult to repair, we can switch to mini open approach. And we need instruments such as straight and curved elevators to mobilize the cuff, and RF ablation also to mobilize the cuff. And we need a bird beak passer instrument to take bites in the cuff, lasso, or sometimes we need antegrade passers such as scorpion or first pass. Some surgeons also do this subscapularis with a 70-degree scope, which they say is gives better orientation to the subscapularis. So there are 2 types of techniques. One is inside the box and outside the box. So we discuss both where we can use these techniques in the next slide. So anchors, the advantage of using a metal anchor is that you can just punch it in and start your repair. It is a single step insertion. However, if we go for peak or bio anchors, it's a 2-step process. We need to put the owl and then put the anchor. And sometimes there may be some struggle if there is any trajectory mismatch. And usually single row repair is done. So this is the algorithm for using the approach and number of anchors according to the type of the tear. So type 1 and type 2 tear, you can usually manage to do the repair with the posterior viewing portal, 1 anchor and antegrade sutures, single row. For a type 3 or a type 4 tear, we may need to switch our portal to anterolateral viewing portal, that is outside the box technique. And we may need multiple anchors, and we may need to use retrograde suture passing devices, and sometimes senior surgeons also do double row repair for subscapularis. And for type 5, it is more like a salvage procedure. So this image illustrates the importance of doing a subscapularis repair in a massive cuff tear. You can see in the first image in the A, there is a subscapularis and suprainfra, all 3 are torn. But in image B, when you see that subscap is sorry. You can see that when we repair the subscap, the supra and infra almost comes back to the footprint. And this also in the second image also, that is the same illustration, how the importance of doing subscap repair in a massive cuff tear, how it helps in bringing back the infra and supraspinatus back to the footprint. So coming to the technique, we can visualize the footprint at the lesser tuberosity. First, we do the routine diagnostic scopy, and then we look at the footprint. You can see how the remnants of the torn subscapularis is seen at the footprint. So this is a sure sign that we are looking at the correct landmark, and this is where we have to bring back our cuff. And next step, all the surgeons recommend to do a biceps tenotomy because that improves our working space for doing the subscapularis repair. So all the literature suggests the first step of subscapularis repair as doing the biceps tenotomy as the first step. So once that is done, this case was something like a 2 or 3 months old injury. So I'm just trying to pull back the subscapularis back to the footprint. However, it's not coming and there is lot of tension. That is usually due to the soft tissue adhesions around the cuff. So the next step would be to do a soft tissue release, either with the elevators or with the radio frequency probe. So we need to release superiorly, inferiorly, anteriorly, and posteriorly. So once the release is done, then we can now you can see that cuff is mobilizing comfortably, and I'm able to bring it back to the footprint. So this is the important step in doing a subscap repair, adequate soft tissue release around the subscapularis. And next is the footprint preparation and anchor insertion. We need additional portal that is something like an anterolateral portal. And we can put a cannula for comfortable suture management. And we can put a suture straight away through the cannula. So once this is done, we can take another additional portal where we can park where this is a double loaded anchor, we can keep 2 sutures in this and park 2 other sutures in the additional portal. So you can take a bite with a bird beak instrument. So that is what I do in my cases. So we just pierce through the substance of the subscapularis and take a bite with the bird beak. And then it is taken through with a retriever back into the our cannula. And then we tie the knot. So first knot is being done. So once this is completed, then we repeat the same step. We take our bird beak again through the anterior portal. We pierce it with the bird beak through the subscapularis. And then again, we use a retriever, which is coming through the cannula, take the suture back through that. And once the suture is shuttled, again, we can put the knot and complete the repair. We can use a sliding knot or we can use multiple half hitches. So the repair is completed. Now you can see the subscapularis has come back to the footprint and the repair looks satisfactory. So to conclude, the increased diagnostic awareness during the history taking and physical examination are the first steps to diagnose a subscapularis tear. So as a beginner who are starting their practice in arthroscopy, this is very, very important. We need to am I audible?
Yes.
Yeah, I'll just finish off. And again, in the imaging, as I said, using an axial section and looking for biceps section helps in diagnosing the tear. So once the tear is identified, now the aim is to do a repair. So we can use for a simple Lafosse type 1, type 2 tears. The inside the box technique is much convenient, and we can do the repair by that. Once the proficiency of the surgeon increases, we can switch to the outside the box technique, and we can progress to do more complex repairs. So for surgeons in early learning curve, I think inside the box technique with a single anchor that is usually a knotted anchor based repair is preferable. Thank you.
Excellent.
Thank you, sir.
So let's start with Ben. Ben is around.
Sir, in subscapularis repair, when
Yeah.
we are approaching that tear
Benjamin?
arthroscopically, we know that subscap has a good, huge amount of.
Just
Okay, sir.
hang on. I was just wondering if Benjamin is still around.
Yes, sir.
Yeah.
Yes, sir. He is
Yes,
there.
sir.
Yeah.
Hi, Ben.
Tell me. Yeah, I hear you. Sorry.
Oh, fantastic. Thanks
Yeah,
for
I hear
sticking around. Thanks for sticking around. And so I just want your take on subscap. So how do you do your subscap repair? What position do you routinely operate your cuff? Do you always sacrifice the biceps? Do you do the
Yeah.
intra-articular repair or the out of the box? Do you change the technique depending on the size of the tear and all that? Yeah.
Yeah. So as you mentioned before, for the lower grades, so Lafosse Tussaud classification 1, 2, 3, I do arthroscopically, start inside the box, and then if it's you need to release the MJGL too deeply, or retract the tendon, or release the coracofemoral superiorly, then I switch to outside the box. But for the more higher grades, so 4 and 5th, I always go open. You know why? Because
Yeah.
I can switch to tendon transfer. If I need, I don't think twice, because I know that open repair in subscapularis, it's always stronger than arthroscopically, because the footprint of subscapularis is really, really big. And if you want to do it arthroscopically, you spend a lot of time to release all the structures, even if you are super skilled in 30 minutes, at least 40 minutes. But with open technique, you do it really fast and strongly. We are talking about big subscap tear. So my advice for young surgeon is, if you are not sure how to do it, the open way is the safest way. So you just find the rotatory interval, you release it, look just the biceps, and you are directly on the subscap. If you are skilled, yes, arthroscopically for sure. But for the beginners, I suggest to go for bigger tears for open.
So when you do arthroscopically, what's your position?
Yeah, I doing lateral decubitus with traction. All my patients are awake.
Okay.
Interestingly, I don't lower a lot of pressure. Blood pressure is quite high. This is a special thing. So because my patient can go home almost immediately, because if you don't lower the pressure, the patients are perfect. Okay, yeah, you must know where the bleeders are, especially the one in the lower subscap. And if you do the tenodesis of the biceps, this was also your question, you in big subscap tear, you must do it or subpectoral or suprapectoral. You are not able to do it intra-articular because mostly of the biceps are luxated anteriorly.
So when you do it in the lateral position, you just open it in the lateral position only. You just lower the traction and just you open it up.
No. I for open procedure I do in beach chair. But if I want to repair it arthroscopically, so for the first, second, third grade, I put the patient in lateral. If on MRI I saw that the rupture is too big, I go directly to the beach chair, start with arthroscopy, look if it's repairable or not, and then switch. But 95% maybe you can repair it in lateral, maybe 5% you have to start in beach chair.
And when you do it in the lateral position, when you do the inside the box, do you release the comma or do you try to preserve the comma tissue?
Always preserve. I always try to preserve it.
Preserve the comma tissue.
Yeah, always.
Okay. And do you do any tendon transfers for subscapular?
Yeah, as I told you, if I have any doubt that I will be not able to repair it correctly, or the patient is really young with high grade, I prefer to do it open, as I tell you before, not because I'm not able to do it, but because I think that the open repair in those big rupture are easier. And sometimes it happens that they are so retracted and the quality of repair is not good. Then I decide to do, or I do a latissimus transfer, or I opt for the PEC transfer. Usually I try to do with the latissimus if it's not able, because you have to enlarge quite a lot the incision if you do it with latissimus. I'm not able to do arthroscopic latissimus transfer pro subscap, so I'm not able to do it.
That is not needed. You don't need to do an arthroscopic latissimus dorsi. Why do you want to do it? It's much more simpler.
Jean Cany and some big names around Europe, they are doing it, but I'm not able to do it arthroscopically.
Yeah, there are some things.
I think for subscapularis, it's a PEC major transfer which is most preferable than LD. Yeah, Karthik, what did you say on PEC major versus LD?
We used to do PEC major, but now Bassam has shown that the latissimus dorsi is much better. It is an adductor. It's just there. And I haven't personally done latissimus dorsi yet. I've done a couple of PEC major transfers before, long time back. Now I sort of tend to repair most of my subscaps, and I think that the high-grade tears, usually they act like a tenodesis. The subscap, it acts like a tenodesis. Even if it doesn't heal, there is some scarring and it works quite well. So, and I do most of my, I do all my thing in B chair, and most of my repair is inside the box. I do intra-articular. So sometimes I come outside, release everything, and then come back again intra-articular to do the repair.
So it's a completely different story when we talk about subscap, so antero-superior tears or posterior-superior tears. When we talk about posterior-superior tears, I've always tested in lateral decubitus. I use a gynecologic arm holder to put the arm like this, and I do a small 5 centimeters posterior mini open, and then the rest of the procedure is arthroscopic. When we talk about antero-superior tear, so subscapularis, I do it open, and you need to enlarge a little bit more the incision, at least to the level of the insertion of the PEC major. So the incision becomes quite big. So it's not a mini open, but it's a even bigger incision than for the arthroplasty, I will say, because you need to release well the latissimus. Try to preserve the teres if it's possible. Sometimes they really stick together and it's difficult to bring it out. And what is the most danger area? It's the radialis nerve and the axillary nerve. They made a triangle. So you don't need to pull too much on those, and you need a good release, because sometimes you may have paresthesia. Usually they dissolve, but you must be careful when you do the LD transfer because of the radialis and axillaris. This is the only problem. Otherwise, the procedure is the same like Episcopo in reverse. The only problem is you have to go a little bit too high now.
The two important points which Ben brought out, two important points. One is never hesitate to open when you are doubtful or when you are starting. So one is, as Naresh was saying, it's not that you can put one anchor and do an intra-articular repair if you are just beginning for a large tear. If you think it's a large tear and you're not able to manage, just don't hesitate. It's just a straightforward. Everyone knows how to do a deltopectoral incision, and subscap is just in front of you, sitting and staring at you. You can do a robust repair, especially in young patients, and then give them a very. And the other important thing which Ben told is about differentiating between anterosuperior and a posterior-superior cuff tear. Now, in a posterior-superior cuff tear, where there is a massive supra-infra tear, your subscap is just an additional tear. So you put the most important thing, if the patient has an exnotation lag, the patient has a pseudoparalysis, you're trying to repair the supra and the infra robustly, then you put the supra infra robustly and you can actually just tag the subscap and repair it just like that. But An anterosuperior tear is a full thickness, probably a Lafosse type 4 tear of the subscap and probably a small supra. Here, the subscap takes precedence over the supra and the infra. Subscap is because you are looking at an anterosuperior escape which doesn't have any salvage. So there, if you can't get it arthroscopically, if it's an acute tear, if it's an easy tear, it's not bleeding, not much synovitis, I think you can get it arthroscopically. You can put 2 anchors, all the one down, all the way below in the medial, in the footprint, and then one up at the top. But when you do that arthroscopically, I suggest you tie the inferior anchor first, not like subscap, like the other cuff tear. If you're tying everything later, here you might have to tie it first inferiorly and then put the superior anchor and repair, maybe add a lateral row, which we've done. But otherwise, if you are in doubt, I think you should never hesitate to open it and augment it with this thing. So,
Yes, sir.
so I think that was an excellent discussion. Thanks very much for presenting those cases. Any questions, comments?
No, sir.
Yeah,
Not from
Dr. Ram and Karthik. Yeah, so how do you plan for when you will do for a LD transfer or lower trapezius?
No, the lower trap is preserved for supra and infra tear. So when there is a posterior cuff tear, supra infra with an intact or repairable subscap, then we do a lower trapezius transfer. Now, when there is a subscap tear, like an anterosuperior tear, where there is the predominant component is a full thickness subscap tear, then we do we were doing pec major earlier. Now the tendon which is proposed is the lat dorsi, because the lat dorsi is just below. It's the pec major area. It's more of a in the line of pull, so it's better. It is an internal rotator. In the line of pull, you can put it back, and that's.
Yes.
Do you still do pec major, Ben?
So pec major, the story is really interesting if you have time. So everything starts in Switzerland with Gerber. Professor Gerber, yeah, he started using it, but he really don't know how to explain why this transfer work, because you take maybe just part of the pec, bring it a little bit superiorly. The vector force is the opposite basically, because the pectoralis major comes anteriorly and the subscap comes posteriorly. So how can you rotate the arm with a completely opposite vector force? And also Bassam Al-Hassam and other big names around the world don't know how to explain why pec major pro subscap works. One explanation that was said on the congresses is that it just stabilizes the head. So it don't have a lot of rotation effect, but it just stabilizes the effect. And then we have latissimus dorsi, teres minor, so other internal rotators who do the job. So basically we are before what I said at the beginning. Everything is the stabilizing of the head, so to have the fulcrum of the rotation. So this is the explanation, at least from the experts, why pec major transfer works. Even from biomechanical point of view, it's completely a wrong procedure. But personally, I did just 2 cases. They somehow works. The strength is not perfect, but at least they can rise up the arm back. No.
Thank you, Benjamin.
Yeah, lat dorsi seems to be more rational. Again, pec major, pec minor, you can do pec minor, but you have to bring it underneath the coracoid. Then you are worried about the brachial plexus and all that. So I think lat dorsi is a reasonable answer in those situations. But I think, having said so, I think most of the situations you can get back the subscap, unless it's like a chronic 4-year, 5-year-old tear with anterior escape. Already anteriorly it is subluxing, like the type 5. So fantastic. Any other question?
Just one comment, guys. Just one short comment. Now, at least in Europe, we are doing quite a lot of Laterge, and I know also a few of Indian people like Sharma, my friend. I don't know if it's looking. We are now dealing with more and more subscap rupture due to Laterge. So if you don't know how to do correctly the Laterge, you damage the subscap. And if you damage the subscap in a young patient, unfortunately, you have just 2 options. Or do a transfer, or you do a reverse. Because if you have shoulder with subscap rupture, it's a big problem. So this is a really, really hot topic now in Europe, and I think also in India in a few years will be how to deal with those young patients with subscapular after Latarjet.
Totally agree. I think it's a very important thing. But now, when you do a subscap split, how does the subscap actually? What do they do? Do they detach it and reattach it? That's why the subscap ruptures, or what happens actually? Do they detach the? Do they divide the tendon too much? Why does the subscap actually rupture post Latarjet?
Why? There are many theories. One theory is too aggressive retraction. So you put too much traction on the subscap and you just split the inferior part completely. The second theory, it's too much release of the capsule. You go too superiorly and the tubular part that is the stronger one, it goes. The third theory, it's that you take away too much capsules or completely away all the capsule because you need a good view.
Yes.
And then you end up with a really thin tendon and just a small rupture, and it went. But I did the youngest case in my life of reverse, 26 years old, because of arthrosis and subscap was gone completely due to Latarjet. So, and you can imagine 26 years with reverse, but you can't do nothing else. This is the problem. If you don't have subscap, and if you have arthrosis, bye-bye.
I think that's an important point. I think we actually studied some of our patients after Latarjet looking at subscap strength at 1 year, and we found that some patients had low strength. But that means we attributed to a lot of retraction and some fibrosis. But tear is something which is catastrophic. So for all the young surgeons out there starting out with your Latarjet, you have to be very careful. Thank you, wonderful. Thank you, Benjamin, for bringing so many wonderful points in all the aspects, right from cuff to Latarjet to subscap. Thanks a lot for joining us. Over to the IAS team.
Yeah. Thank you, Benjamin, for being here. Thank you, Sarthak, Manivanan, and Satish. And thanks to Dr. Ramchandran Karthik for moderating this session. So I would like our convener, Dr. Sridhar and Dr. Neha, to give vote of thanks.
Yeah. Thank you.
Thank you, guys.
Thank
See
you
you.
very much. Our expert speaker from Slovenia, Dr. Ben, our moderators, Dr. Ram and Dr. Karthik sir, and our case presenters, young budding arthroscopic surgeons, Dr. Sarthak, Dr. Mani, and Dr. Satish. And definitely thank you to Team IAS for supporting us and giving us this opportunity to conduct all these monthly webinars. So I think this is it for today. So we can sign off.
Thank you all. Thank you.
Thank you.
Thank you,
all.
sir.
Thank you.
Thank you so much.
Thank you.
Good night.
Thank you. Thank you. Thank you.
Thank you, sir. Thank you,
Thank you.
sir. Thank you, madam.